Well, I've been in practice now 37 years, and the first 25 years of my practice, I was just doing the standard of care. And believe me, I had my share of patients who suffered heart attacks and strokes, and my share of patients who died from heart attacks and strokes. And it hurts when that happens. When you're in general practice, your patients are your friends. And when they suffer, you suffer. So I felt bad that the standard of care obviously wasn't good enough for my own patients. So I started looking for peer-reviewed evidence that I could apply that could improve the situation and reduce their risk further. And it so happens I got a bad family history too. My oldest brother had a heart attack at 59. My mother had a heart attack, eventually died of heart failure. I was 5 years old when I watched my father's mother drop dead of a heart attack. My mother's father dropped dead of a sudden heart attack. My mother's mother had a stroke. So I was riddled in my family history. So I had personal reasons as well as my patients. So I started looking at other ways. And I think coming at this wellness, maintenance of wellness in your patients from a general practice standpoint probably actually helps, because the disease, the arterial disease, does need to be treated as a systemic problem. So when you're in general practice, you look at the body as a whole, from the head to the toes, every organ, every part of it, also the emotional aspects of healthcare when you're a general practitioner. When cardiologists, of course, are great, but they're zeroed right in on the heart. And when you're treating arterial disease, you have to look way beyond the heart. Again, our journal of arteriology, we believe, will stick. To really have an impact on maintaining overall wellness, you have to keep these highways in our bodies, these arteries that supply every part of our body with the needed oxygen and nutrition to stay well. You have to keep those arteries healthy. You can't just zero in on one little artery. Well, I'm going to fix that. The problem's way beyond that. So I think coming at this through a general perspective is very helpful. Because in general practice, you always do pay attention to anxiety and stress with patients and how well are they sleeping, what are their interpersonal relationships. All that's extremely important in terms of keeping the arteries healthy. Heart attacks are still the biggest killer in this country. Like you were saying, about 1.2 to 1.5 million people have a heart attack in this country every year. About 400,000 of them die. And what's extremely disturbing to us is that about a third of all of those heart attacks are occurring in people who've already had one. The recidivism is incredible, especially when you believe, like we do, that we now have the science and therapeutic agents available now to shut this disease process down, that nobody needs to have a heart attack. We really need to look at the whole body and look at this disease we call atherosclerosis. That's where you do collect cholesterol in the wall of the arteries, as a systemic problem throughout the whole body, and not just zero in on the heart or the brain. One reason the units in this country that do dialysis are literally overflowing is due to arterial disease of the kidneys. People have issues with their intestinal tracts because they get these many events in their intestines that block the flow of blood. People are losing extremities daily because of arterial disease. And it needs to be looked at and treated as a systemic problem. So I know my partner and I have coined a new term that we believe will stick, and that's arteriology. The tests that we started using years ago, something like 18 years ago, to accomplish that was looking for calcification in the coronary arteries. That can be done with high-speed X-ray. Initially, it was done with electron beam tomography, And if you see calcium in the coronary arteries, that proves that you do have the disease of atherosclerosis. And again, if you have that disease, if you have a collection of cholesterol in the wall of the artery, the potential to have an event, a heart attack, does exist. So if you have a positive score, we know you have disease, and that test doesn't require much x-ray whatsoever. It's equivalent to a couple of chest x-rays. It's very easy to do, and the cost can range anywhere from $100 to $300. So it's not very expensive. And for the last 10 years, we've started using, as a workhorse for us, the carotid ultrasound as well. And it's not expensive either. It can range in price from $100 to $200. And it looks at the carotid artery with ultrasound for the presence of this collection of cholesterol that we call plaque. And my partner and I coined the term cat in the gutter. If you can imagine the plaza in Venice, Italy, where they have the deep square gutters and there are pigeons all over the place, if you look carefully in any of those plazas, you'll usually see a cat somewhere in those gutters, just down, hunched down far enough that the pigeons can't see him. And all of a sudden they can leap out and get that pigeon. So we call this disease plaque or cholesterol collection the cat in the gutter. So it's usually sitting there silently, and patients aren't aware of it. Patients aren't going to come into a doctor's office and say, I think I'm starting to collect some cholesterol on the wall of my artery. And they found out 7 or 8 years ago that when it starts collecting, it actually collects away from the hole that the blood flows through. It's what we call remodeling. So the body's smart. So when you start to collect the cholesterol, the outside wall of the artery stretches. So it allows the cholesterol to collect away from the hole. So there's no way you're going to feel it. And most people aren't going to know they have a problem until the cat leaps out, and then you get the blood clot that actually blocks the flow of blood. So we believe any good prevention program needs to be anchored in assessing their patients for this, quote, cat in the gutter. Do you have a cat in the gutter? If you have a cat in the gutter, the potential to have an event does exist. We've had data for decades telling us that a lot of people with horrible cholesterol are never going to have a heart attack, and a lot of people who have wonderful cholesterol are going to have a heart attack. And the emphasis, because of the statin drugs, has been placed upon this LDL cholesterol. It's just one of many cholesterol particles. And all of the cholesterol is important, the good, the bad, the ugly, the quantity, the quality. So it's much more complicated than simply just looking at LDL. For example, we have a cholesterol in our body called HDL, and it has various qualities. So some of the HDL particles can actually act like vacuum cleaners and get into the wall of the artery and start to clean up those cats, actually. So you can get regression of disease if you get that high enough. So simply taking a look at the basic cholesterol isn't adequate, and there are inherited cholesterol problems, such as one called lipoprotein A, that unless you measure it directly, you're not going to know whether or not your patient has that. And it was proven several years ago in publications in our Journal of American Medicine that were genetically based studies that proved beyond a shadow of a doubt lipoprotein A causes heart attacks. And actually, the European organization has called for the measurement now of lipoprotein A in all patients. And if it's 50 or higher, they should be treated. And the best therapy for it is niacin, vitamin B3. To simply look at heart attacks as a result of cholesterol it's way more complicated in a way than that. I mean, you have to take a global look to determine a patient's risk. Things like how much you sleep make a big difference. What's your stress level? What's your anxiety level? The health of your mouth. that can all result in a problem. So the first thing to do is find out if you have a cat in the gutter. If you have a cat in the gutter, you do have risk for an event. What causes the event is inflammation, or we like to call it fire. If you have fire in the wall of your artery, that cat's going to jump out. So there's simple tests, urine and blood tests, that'll tell you if you have inflammation in the wall of your artery. And that's what triggers events. So you can be full of cats in the gutter, and if you keep the artery cold, they're not going to jump out. So if you keep the arteries cold, you're going to keep the body warm. If the arteries get hot, your body's probably going to get pretty cold. So it's kind of that simple, but inflammation is a manifestation of numerous other issues, such as being pre-diabetic, or again, being anxious, or not getting enough sleep, or being depressed, not eating right, etc. So the inflammation is a manifestation of numerous other potential issues. So each patient needs to be evaluated as a unique individual. And one of the problems we have with the quote standard of care, that's always based upon treating that patient, that one unique individual, as the average of a huge study population. Well, nobody's the average of a population. Everybody's wonderfully unique. And to get where we need to with prevention, you have to personalize your care. And that's why we started utilizing genetics over 10 years ago. You can't get any more personal than your genetic makeup. That's what makes you the unique biological individual that you are. And when you gather that genetic information, it not only can help with risk assessment for your lifetime risk of a heart attack, but it also can impact what therapies and what management you dictate to that patient to minimize their future risk. So the future of medicine is going to be heavily rested in genetics. We have indisputable evidence that heart attacks are still the biggest killer in this country, and strokes are the biggest cause of disability. So we know the current system isn't working. With our method, my partner and I actually attach a quote guarantee to our work. So the patients that we personally take care of for the last 3 years, we believe the science has advanced to the point where we can guarantee our work. So even when we know they have cats in the gutter, we see a lot of patients that don't get to us until the cat's already jumped out. So they've already been stented or bypassed. We still will guarantee our work. We believe we can shut down the disease process and keep the artery cold in each patient. So if our patients that we're personally taking care of were to have a heart attack or stroke under our care, all the fees they paid to us during that year, we would refund to them. We never had to refund anybody. So the last time we had a patient that had an event was 10 years ago. And we see a lot of high-risk patients. Some people say, well, you just treat the worried. Well, no, that's not true. We treat a lot of patients, like I say, who come to us after they've already had 16 stents every year. I know I had a patient that came in not too long ago, and she said, well, I wanted to get here in May because each June I have to go in and they put another stent in me. So I'm trying to see you before they have to do the next one. Well, that was over 1.5 years ago. They haven't had to do another one. The main management to reduce risk of a heart attack or stroke definitely is lifestyle. They'll never develop a pill that can get anywhere close to the risk reduction you can achieve with the right lifestyle. And when we say lifestyle, we're not just talking about diet. That is included, and we actually use a gene, the ApoE gene, which is a big determinant of how you metabolize or break down whatever you put in your body. We've directed our dietary advice on that gene for over 10 years. So again, it helps personalize. There isn't ever going to be a one-size-fits-all even with diet. We're all genetically different, so there'll be nuances that should be a bit different for each patient. But diet certainly is extremely important. Exercise, and fortunately, the data tells us you don't have to be a gym nut to get the exercise. You need to have a huge impact. Simply getting some type of, like a brisk walk, 22 minutes a day, cuts your risk 14%. That's huge. The biggest bang for the buck is actually the first bit of exercise, the first 22 minutes. So, and that can even be broken up. So you could do 2 11-minute walks a day. It doesn't have to be all at once. But exercise is extremely important, and we believe should be 7 days a week. But it goes beyond just that. You need to sleep. And you need to sleep well. And you should be getting 7 to 8 hours of sleep most evenings. You need to keep your stress level down, the anxiety level down. Things like listening to music you enjoy for half an hour a day has been shown to improve the function of the artery as much as some of these drugs that we have. I know my partner who takes care of my risk has given me a prescription not to listen to rap, because it has to be half an hour of music that you enjoy. Rap would kill me. I'd probably be dead if I had to listen to that. And laughing, that's one of the best things you can do for your arteries. So one of my nurses in Texas got trained as a laughter yoga instructor. So patients can join laughter yoga. That's wonderful for them. So there are lots of simple things like that that are very important, but often overlooked. Again, too many people just get hung up on this LDL cholesterol. I have one gene known as the, quote, heart attack gene. It's 9p21, and it places you at increased lifetime risk of a heart attack independent of any other risk factors that we know of. Your weight, your blood pressure, your age, etc. And genetic tests are the future of medicine, but the exciting thing is they're here now. We've been able to measure that gene in our practice now for 5 years. And it has an impact on knowing the patient's lifetime risk, and it has an impact on how aggressive you want to manage other known risk factors. And some people, genetic tests are too expensive. We would argue they're the least expensive tests you can possibly obtain. Why? The clinical utility never disappears. In other words, even after you're gone, your offspring can utilize that information. Their offspring can utilize that information. Think about other tests that we do, such as cholesterol. What's the clinical utility of it in terms of time? Maybe a month. We'll remeasure it in a month or 3 months. It has a relatively short lifespan in terms of its usefulness, whereas genetic tests are useful forever, even after you're gone.